and also features of third space collection, we can think of a nephrotic syndrome. And nephritic syndrome can also be in mind, but since the lady was not previously known hypertensive and there is no history of hematuria, so that will be in the second line of diagnosis. Now, a case of nephrotic syndrome who comes with nephrotic range of proteinuria can be because of diabetes, minimal change in glomerulonephritis, membranous glomerulonephritis, amyloidosis, or FSGN. Now, the lady is not a known diabetic, and B and E, that is minimal change and membranous glomerulonephritis, usually manifest by the 17 or 18 years of age. A lady coming at 65 years of age with just 2 months history is less likely to have these two. FSGN, again, previously not a known hypertensive. So what we are left with is maybe it is a new case of diabetes mellitus or amyloidosis. Now coming to the nephrotic syndrome, the common causes are hepatitis B.
Heart sound is muffled.
Heart sound was diminished.
Can it be hypothyroidism with effusion, pericardial effusion?
Yes, sir. Patient is having orthopnea. History of orthopnea is there, and there is clinical evidence of pleural effusion also, and there is ascites also. So all the third space are filled with fluid in a case of hypothyroidism. But the thing is, hypothyroidism coming with anasarca with just 2 months of history is, and with frothy urination, because in hypothyroidism passage of high protein urine is less likely.
That also you should keep in mind. One case was admitted in my ward with pain abdomen and he was in failure. Liver was enlarged and heart sound was muffled. They referred the case to that was hypothyroidism with pericardial effusion. And he was in failure. That also will come as a TB.
Pericardial effusion will have some amount of tamponade effect also, like prominence of neck veins and all, which was not there in this case. So hepatitis B and HIV are the most common infections causing nephrotic syndrome, and among the chronic illnesses, diabetes, amyloidosis, and even sickle cell disease. Multiple myeloma and lymphoma, especially the Hodgkin's type, are common among malignancies. Among connective tissue disorders, SLE, rheumatoid arthritis, and mixed connective tissue are the major culprits, and NSAIDs, D-penicillamine, lithium, castopril are the commonly used drugs that can cause nephrotic syndrome. Now coming to the nephritic syndrome, post-streptococcal glomerulonephritis is the most common, associated with subacute bacterial endocarditis, hepatitis C virus. Among causes of vasculitis, it's once again SLE with Weisner's, with pastures, enoscolin, and polyarthritis nodosa. So now coming to the investigations, as we can see, patient was anemic with hemoglobin of only 7.2. Total count was normal with ESR grossly raised at 120 millimeter in first hour. Renal parameters were also deranged. Serologically, patient was non-reactive towards hepatitis B, C, and retroviral. Liver functions was normal except that alkaline phosphatase was highly raised at 245 international units per liter.
Albumin is 1.4, no?
Albumin also, AG ratio is also altered at 0.33. Albumin is 1.4, globulin is 3.6. BTCD and other bleeding and clotting profiles were within normal limit. Lipid profile was also grossly deranged, triglyceride of 212 milligrams per deciliter, cholesterol 354 milligram per deciliter, HDL 62, LDL 230, and VLDL 62 milligram per deciliter respectively. Now, workup for tuberculosis was negative, but in urine routine examination, the albumin was 3 plus without any evidence of loss of sugar. There was no cast or RBC seen. Culture sensitivity from the urine sample did not show growth of any pathological organism. Now, if you can see the chest X-ray, there is obliterated CP angle on both the sides, suggesting of pleural effusion, which is more marked over the right side compared to the left. And USG also shows there is a collection of fluid in all the third place. The GB fossa, as we can see here, has got evidence of fluid collection. There is a significant ascites over here, and also there is fluid in the pleural spaces. So reported as bilateral pleural effusion with reduced corticomedullary differentiation of the kidneys. And also a CT was done which showed features of ascites with minimal pleural effusion over the right side and hepatomegaly. ECG was low voltage with normal sinus rhythm without any ST or T changes. Echo was done. There was no evidence of any pericardial effusion. Left ventricular ejection fraction was good at 73%. However, there were mild MR with AR. Now, due to the foggy urine and presence of 3 plus of albumin, 24 urine protein was also done, which came out to be very high at 10.6 gram per 24 hours. ANA and RA factor screening for was negative. However, patient was positive for dsDNA, which was 27.1 international units per ml. So, patient was given albumin infusion with blood transfusion and other supportives like antibiotics, diuretics. Due to the anemic picture, bone marrow was also done, which did not show any increase in plasma cells. However, on SPEP, there was a M-band detected in the IgG lambda immunofixation profile.
Serum protein electrophoresis.
Now, in a case of heavy protein loss through urine and apparent no other clear-cut evidences, bone marrow was also done. A renal biopsy was done, and in the biopsy report, it came out to be an amyloidosis of AL type. It was reported as 12 glomeruli showing pale eosinophilic pus-positive material in the mesenchyme and basement membrane, showing apple bean bioinfiltrations. Tubules showed acellular amyloid material with around 30% of atrophic changes. Vessels also showed amyloid deposits. Immunofixation was negative for IgA, IgM, C3 and C1q, and lambda kappa chains were also negative. Congo red stain was positive for amyloid. So it was reported as amyloidosis of AL type. This was the cherry little bit blurred, but this was the slide. And as we can see, there is pus positive amyloid deposits. And finally, because the patient was positive for M-band and established case of amyloidosis, patient received bortezomib of 2 mg IV, day 1, 8, 15 and 22, with injection dexamethasone 20 mg IV, day 1, 2, 2, 8 and 9, 15, 16, 22, 23. Just like when we are giving bortezomib, we have to give a chuvate backup. Tablet thalidomide for 50 mg for 7 days, and when if the patient tolerates well, we can go up to 100 mg for the remaining 14 days. Cyclophosphamide was also given on day 1, 8, 15 and 22, and tablet acyclovir was given because there was evidence suggestive of viral involvement also. Patient was followed up with renal parameters, which has progressed but not satisfactorily, and patient tolerating chemotherapy well at present admitted in the ward. So the idea of presenting this case is that amyloidosis is a multi-system disease and it can be picked up clinically also. In this case, there was reduced heart sound with nail dystrophy, with heavy proteinuria, with anasarca, and on investigation we found to be anemic with a deranged lipid profile with raised renal parameters. So retrospectively, if we analyzed, all these are telltale features of amyloidosis affecting the renal organ. As we know, the kidney is the most common organ affected in amyloidosis. So a high index of suspicion is needed, and clinically also it is possible to suspect a case of amyloidosis. As we can see, it has a multi-organ involvement. So a early detection will help us, and also treatment has got reasonably good prognosis. The 2-year survival rate of these patients are better when the treatment is initiated early. So one should keep in mind about amyloidosis in such type of presentation and do the proper workup. These are my references. Thank you.